one of the most renowned persons in the field of bioethics, Dr. Anant Bhan. A very brief introduction is in order because he is very relevant in the present context, primarily actually an MBBS doctor from having done his master's from bioethics, from University of Toronto, a stalwart in healthcare, Dr. Bhan. His work is focused on ethics and equity in health, mental health, digital health, public health ethics, research ethics, community connectivity, and their related fields. All these have come in sharp focus during this present corona pandemic. And Dr. Bhan has been pretty active during this entire corona crisis as well. Published extensively in various national and international journals. He presently is the president of Indian Association of Bioethics. So over to you, Dr. Anant Bhan. Most welcome. We all are looking forward to hear your wise words. Over to Dr. Bhan.
Thank you so much, Rajesh ji, and thank you also, Mr. Haldar and the Policy Perspectives team for this kind invitation to be part of this very interesting webinar, two-day series. My apologies that I couldn't join yesterday. I had some work commitments and calls around at the same time when the first day deliberations were happening. But I did manage to speak to Mr. Haldar and Dr. Kar to get a sense of some of the discussions. And I will try to add on to those and hope there might be some overlaps, so apologies in advance with the other speakers. But I think the idea being that we are all throwing out some of our own reflections and thoughts, which might sometimes be seemingly a bit rambling, but hopefully will contribute to the discussions. I'm going to share my screen and request that if someone can confirm that you can see my slides.
Yes, it is visible, Dr. Bhan. Please go ahead.
Okay, great. So again, as the focus of the discussions today, as we've been having, is around, what does this pandemic of COVID-19 tell us about our own response, of our own health systems? And maybe I just want to probably in this 20, 25, 30 minutes talk about my own reflections on what this pandemic tells us about our health systems. Now, as Rajesh was alluding to, we are among the countries which had one of the earliest responses to the COVID-19 crisis by virtue of taking steps like lockdowns. And, we are now in lockdown 3.0. There might be a lockdown 4.0, as the Prime Minister indicated in his speech a couple of days ago, the contours of which are being fixed more at the local level, at the state level, presumably, though there is probably national level decision-making involved. But it's important to also remember the size of this lockdown. It's pretty much the largest lockdown in the world. And it almost, at least by a fair quantum, higher than the second largest lockdown, which is in China. But obviously, the lockdown is meant to be a public health measure, but its implications are also socioeconomic in nature, as we have all seen. And those implications, I think, are troubling from a policy perspective, and I think also influence then what kind of decisions you take about extending public health measures versus then loosening measures to ensure that people have access to being able to earn, for example, those who are the daily wage earners or laborers, etc., or at least ease ways for them to go back to their families if they're stuck due to economic migration. And we've also seen these kinds of images in media, which for many of us again are fairly troubling. The fact that there is this large-scale migration and has been described as the largest migration we've seen since partition, probably upwards of 6 crore people traveling back from economic hubs, cities, back to their villages because they do not have any work, they do not have any savings left. Food is in scarcity, and there is a lot of uncertainty in the job market, even the informal job market. But also the fact that during this process, there have been sort of a lot of violations, anything from spraying of disinfectants without any evidence in public health, to the fact that, we've had these many deaths now of people who've been run over by trains, who've been run over by trucks on national highways, etc., and still, no sort of not being able to respond to their health needs, their food needs, their basic security needs. And that also, I think, is going to be a big pressure in terms of what decisions we take, even from a public health perspective. But yet, pandemics also have a habit of telling us about some of our issues. In a sense, they expose the dirty underbellies of our systems, and one of which is certainly our deficient health system. We already have realized through the pandemic that we have a system which has a lot of issues. There is leaky infrastructure. There's a huge shortage of human resources. And this is something which is partly because of systemic neglect. It's not something which has happened overnight just because of COVID-19. It's not like we had a perfect system which is collapsing under COVID-19. As again was pointed out in the introductory remarks, the cases have been steadily rising, but they are not devastatingly high, as has been the case in many other countries compared to our population. And they also expose the gaps in our regulatory system. For example, a lot of interest has been done in trying to purpose and repurpose drugs, vaccine, do vaccine research, etc. But the issue also being that while everything is being tried to be expedited, our regulatory system doesn't have the innovation in it to allow for some of this to happen. So you saw seemingly cutting corners, and that might have implications on safety and due process. But perhaps if we had thought through some of these implications earlier, then we could have designed our regulatory systems and laws to be more efficient, to be able to allow for important research to continue, yet also being cognizant about reassuring the larger public and the system on safety and due process and efficacy, etc. Now, this is just an example of the issues that I was talking about when I was talking about our health system having deficiencies. And this is something which I'm sure many of you have seen before, the fact that our density of health workers as a proportion of our population is fairly low compared to many other countries, actually compared to many other low and middle income countries also, because you might, these are all high income countries, that is not a fair level. But if you compare with many other LMICs and even some of our immediate neighbors like Bangladesh and Sri Lanka, we don't seemingly do very well. And this is not just true of doctors, this is true of nurses, paramedical staff, community health workers, frontline staff, our folks who are involved in transporting emergency cases, etc. And that is something we need to worry about. Now, a lot of the infections right now are focused in urban centers, right? So as if you will see the numbers again, as of earlier this week, the concatenation of cases was primarily in these million plus cities, anywhere from Mumbai, Ahmedabad, Chennai, Pune, Indore, Jaipur, Kolkata, Surat, Thane. But the challenge now is with the easing of lockdown and this movement that we've talked about earlier, the migration that we're seeing, which is a COVID-19 migration, part of which is probably due to the crop season, but it's largely due to lost jobs and uncertainty. These infections will easily travel from urban areas to rural areas. And that is what many of us worry about, that when these infections reach rural area, which have even frailer health systems, then what will that impact be? And are we really prepared in our rural India for this kind of an impact? We are already starting to see these infections climb up in states like Odisha, where migrants are bringing in the infection. And just a reminder, the reason for that largely also is because COVID-19 infections are primarily asymptomatic in nature. And even if you do symptomatic screening, even if you do thermal screening, you're not going to be able to pick them up unless you do RT-PCR testing, which obviously no one is doing yet for migrants, or at least at scale. So you're going to easily miss a lot of infections, and these infections are going back to communities in rural India and could potentially raise a lot of challenges for our rural health systems and could be devastating in some contexts. So this is something we need to all think through and be prepared for. The other area, I think, which has sometimes taken, anything from a racist to a communal angle, is the issue of stigma and the stigma around infection and the stigma around infection spread. So while efforts, I think, have been made in social media, through messaging, even by the government, I think we've failed in many ways in understanding the implications of stigma on our response. And this is a bit strange because I think, we have extensive experience of working with infectious diseases, including diseases with large prevalence such as, TB, HIV, etc., where stigma has been an issue, is an issue. So we could have probably forecasted some of these issues coming through, but the way sometimes authorities have focused on ruthless containment, but not yet thought through the implications of stigmatizing individuals, communities, families, has meant that people sometimes are probably reluctant to come forward for testing, to come forward to being identified, and those who are either tested positive, or their families, or even healthcare workers who are taking care of patients with COVID-19 have been stigmatized. Some of them have been thrown out of their homes by their landlords. Some of them are refused entry, and there has been violence in a few cases. So again, these are two illustrative examples of where households have been labeled or individuals have been labeled for home quarantine purposes. And I'm not going to say that this is wrong, but I'm just saying that we need to be a bit sensitive about understanding the implications of stigmatization on our response and what that could mean for community participation and public participation in our health efforts. Now, a lot of messaging for COVID-19, because the only thing we really know which works actually is both public health measures like hygiene and frequent hand washing, as well as physical distancing. Don't know if there is a vaccine. There are a lot of vaccine candidates. WHO just came out with an analysis around a few days ago, around 110 vaccine candidates in the fray, 8 of which are in clinical development and 102 in preclinical development. A lot of drugs which are being purposed and repurposed for being tried out, but we don't have any definitive treatment available. We don't have a definitive vaccine yet. So in the interim, we only have these measures which we are sure are effective, and maybe you can add in masks if you want. But are these implementable in large sections of our population? How practical are these in rural India, where you might have one family staying in one small hut with 7 to 8 individuals? Can you really practice home isolation for an individual there? Is that something which is practical in high density populations in urban India, where you might have just one community toilet for sometimes 5,000, 10,000 population, where water supply is not 24/7. It only comes at, for 10 minutes at 4 a.m. in the morning, and everyone has to line up for that water. Where food supply might not be something you can get at your doorstep, that basically purchase food for the day from the local grocer. So is that really possible for those kinds of populations to then sit in situ for 14 days as advised and then be able to manage? Extremely difficult, right? So and that is something we need to think through more. Then what is it that we need to do for these populations specifically when you say anything about home isolation or quarantine measures, right? So our advisory is really practical for them. Is frequent hand washing really practical for households which don't have access to running water or safe waters, right? So this is, sometimes we do come out with advisories, but implementation requires us to think through also the implications for specific communities. Now, many states have also come up with quarantine mechanisms where there is paid quarantine for those who can afford, right? So you can get a 3-star hotel, you can get a 5-star hotel and stay there for 2 weeks. Whereas there are these free quarantine facilities, free in inverted commas, because not everything is available. You might still need to get some of this material from outside. But then, quality is a big question mark, and that dissuades people then from going in. If you're not sure whether you will get food, water, if you're not sure if you will have access to communication, if you're not sure if you will be able to contact your families and be able to reassure them that you're okay, would you want to stay for 2 weeks away from them? And, and would the government be able to assure people, yes, that we will take care of you? This is part of our public health measures, and in reciprocity to you coming forward and staying in these facilities, we will ensure that all of your needs are met. What about those who have families which are dependent on them, those who are daily wage earners now? Obviously, now there is hardly a job market for many of them, but in the early stages of the infection spread, when the economy was still functional, when life was relatively closer to normal, these individuals were still having access to that. But if you quarantine them, if you isolate them for longer periods, then how do you deal with it? You need to do then some kind of compensation loss, as has been thought through in other areas like drug resistant TB. Again, the one area which a lot of us who work in the ethics domain, especially in healthcare, have worried about is the lack of evidence in our policy making. So hydroxychloroquine is a good example. For those of you who don't know, hydroxychloroquine is one of the drugs used as an anti-malarial. It's also used in some, in some immune conditions like rheumatoid arthritis, etc. The national government through the ICMR came out with an advisory which said that some high-risk groups like healthcare workers and contacts of lab tested positive COVID-19 patients should take hydroxychloroquine. Because there is, they felt that there was a possibility that it could work as a prophylactic drug. A prophylactic drug typically is something which can help prevent infection. But there was no evidence for this. Globally, there is hardly any evidence. And if there is anything, it is very poor quality evidence, and it's actually for treatment, not for prevention. So was it really wise to actually advocate for the usage of such drugs on a national basis, even for a small section of the population, And what about elements like oversight of these medications? Because every medication, even if it's been around this will have side effects. Only now do we have some studies which are commencing in this domain, and this is worrisome. And what's interesting is some local governments have taken this forward, and from those high-risk groups actually talked about mass prophylaxis. So an example is areas like Dharavi in Mumbai, where the local municipal corporation has said we'll roll it out to the entire population. And again, based on very flimsy evidence. So is it the case that actually what we are saying is that we cannot assure these populations of basic measures of hygiene or physical distancing, given our chronic systemic neglect? So the only thing we can offer them really is mass prophylaxis, which is based on dodgy evidence. And isn't that a very poor substitute for a response? And you have already seen Maharashtra has the highest number of cases. Mumbai is the epicenter of the infection, and a lot of that is being driven by infections in these urban high-density populations like Dharavi. And remember, this is an infection which has been brought in primarily by the middle class and the upper class who have traveled in from abroad. But the implications of that infection are going to be much more dire on the urban poor and the rural poor, right? So that is also an equity question to think through. Again, many of you would have seen these kinds of hypes of therapies which are happening, especially from private hospitals. Convalescent plasma therapy is an example. Governments have come forward and saying, well, we are introducing plasma therapy almost as if it's some kind of a panacea, when it's right now only experimental therapy. There is no evidence yet, which is definitive in nature, which tells us that convalescent plasma therapy works. It might have some effect, but what effect we don't really know till we have enough numbers which have been put through a clinical trial, and some agencies are working on this. But in advance of getting that evidence, should we be actually having this kind of information going out? Now, the research landscape is also interesting. There is actually a lot of research happening. I won't go into details, but even in India, we have research happening in multiple domains, anywhere from virology, diagnostics, tech, therapeutics to data collection, prophylactic medications, etc. And this is very important and exciting. I just checked this morning on the Clinical Trials Registry of India, which is one sort of clearinghouse to see what kind of clinical trials are happening, both observational and interventional. And as of today morning, there were around 75 clinical trials which have been registered. Many of them also, interestingly, from non-allopathic systems of medicine, so Ayush therapies. The other area which I want to hint at is this debate which we need to talk about around the surveillance state, right? Which mechanisms like apps, when they are used, Arogya Setu being a good example, and it being made mandatory for sections of the population. If you work in a government office, if you're going to go board a train, it might be also required if you want to board a flight as and when they start. What implications does that have on privacy, on stigma, on data access, storage, usage, confidentiality norms? I know the government makes certain claims. There are others who differ with it, but we need more transparency around some of that because, again, from an ethics perspective, that is extremely important. I did hint at the fact that also there have been sometimes advisories from parts of the government, especially Ayush ministries, etc., which talk about seemingly efficacy of certain medications for prophylactic or treatment purposes, but again, not very clear on the evidence base. And that is very important at this point of time, because in some states, from what I understand, almost millions of doses have been doled out for free. But then, what impact are they having? Are we systematically collecting evidence? And actually, there are sections within the Ayush community which are advocating for the need to do more systematic data collection here. Now, there are some stars in our response, and the Northeast is a good example. They have seen relatively lesser number of cases. Sikkim is the only state which has not seen any cases. So what does the societal response there and the way they have adhered to norms tell us about what the rest of the country needs to learn from it? One element, I think, which a lot of us have had concerns around is not enough testing, which is extremely crucial to pandemic control. And I think we've been fairly conservative in the initial part. Now we are doing much better, but even now we have wide variation across states. I live in Bhopal. In Madhya Pradesh, we've for the past many weeks been stymied in our response because we have limited lab capacity to process samples. So samples are collected, but they take sometimes days to get processed. In some cases, the government has actually sent samples to Delhi and Puducherry for processing, and that obviously can delay the public health response, and that is worrisome. Now, then what has worked globally and what can our health systems learn from that? So a lot of focus of international media has been on countries like South Korea, Singapore, Germany, and for good reason in many ways. But I don't think some of the other relatively smaller countries, but much well-performing countries have been looked at in as much detail. So Vietnam is a good example, a country of 96 million people, a much smaller GDP obviously than Germany, but zero deaths as of now. And what has worked for them actually is trying to do some basic public health measures right. So they chose prevention early. They closed down their borders. They had travel restrictions, very close monitoring of those who came in or those who were allowed to. Schools were closed early. There was a labor-intensive contact tracing operation. They learned from their past experiences of working with epidemics. Everyone in quarantine was tested. It was not symptomatic. Literally everyone was tested. And that was important because they actually found out that 40% of those who were asymptomatic and in quarantine, who they would have never picked up otherwise, were actually positive. And so they obviously took measures for that. And they had containment zones. They had clear public messaging, which helped. So, I mean, again, some of these countries would be useful to look at because while they're smaller, there is something to learn from them. The one thing being that obviously, we are a much more democratic country and Vietnam is a much more authoritarian country. But, again, there are measures which we can look at. So then what can we do for our own health system? One area definitely is the need for resilience. And a resilient health system is something we don't have because of the leaky infrastructure, right? And this is something which all of us need to pay attention to. We need to learn from the models which work well. We need to address our underfunding. So almost anywhere, the range is somewhere between 1.3 to 1.5% GDP expenditure on health from the government is hugely, obviously, an underfunding and much more lesser than many other countries. We have a large out-of-pocket expenditure, but remember, families are now economically devastated in many ways. And with insurance not yet reaching everyone, what impact will COVID-19 have on those families? When they need to take loans from local loan sharks for simple things like deliveries or cesareans, etc., especially if they're not covered by insurance, then this will be further devastating for them. So we need to look at the impact of COVID-19 from a long-term perspective as well. So yes, we need more funding, but you need to be also smart in how you fund it. The easiest thing for policymakers often to do is to buy infrastructure. You buy X-ray machines, you buy CT machines, CT scan machines, MRIs, etc. You set up buildings, but then you don't invest in human resources to run them. So they keep rusting and they are just available as white elephants without being used. Disbursement is sometimes not on a timely basis. It might come in November and December, and then you need to spend everything by March. You're not able to send it back to the government. So underspending is also an issue with underfunding. Transparency, accountability, governance mechanisms, investment in infectious disease surveillance and disease outbreak, surveillance systems is extremely important, not happening. And, we can certainly learn from our own experiences of dealing with diseases like HIV on an ongoing basis, and also how we did more control in the past. And one example might be actually the need to invest more at the district level in terms of our response. And this is something, health secretaries who have retired like Sujata Rao have also talked about. So in one of our analysis papers, which we published in the print a couple of weeks ago, essentially what we appealed was that a lot of our response has been almost as if this is a T20 match, our COVID-19 response. And it's not, it's going to be a test match. It's a much more chronic response because COVID-19 is here to stay from what we can understand for months, maybe years, we don't really know. And for that, we need to plan more for the medium to long term and not just talk about short-term responses. And part of that is actually having more workforce available, more people who are specifically recruited who can do contact tracing, because that actually will make a huge difference. We don't have enough people on the ground, boots which are going and doing door-to-door work for COVID-19 response. And the recruitment that we are seeing is of this kind, people who are recruited on a daily basis. So staff nurses who are being recruited at 273 rupees a day in some states, sort of insulting for the skill set that they bring in, but also probably, at less than minimum income levels, if you look at national criteria. Also, skill sets like epidemiologists who are being just paid 25,000 per month, and most of them are recruited only for 2 to 3 months. So what kind of a response are we building up? We are only recruiting for a very acute phase and not really for the long-term phase. And what can we learn from states like Kerala, Odisha, the Northeast, as I said, in terms of building on the local expert base, building on their own past experiences in handling epidemics like Nipah, in building strong primary healthcare networks, their own initiative to strengthen government hospitals, supportive decision-making from the top, strong local networks, local self-government, self-help groups like Kudumbashree, their community health worker base, which is in close touch with the community, and how much of that is scalable or implementable in other states, right? So the other one area which I want to highlight, because I think this doesn't get addressed enough, is the impact of COVID-19 on non-COVID-19 care. So areas like cancer care, dialysis, immunization, they are all seeing a drop, and that is something which is worrisome. I think I have probably almost ending my time, so I'll probably go through the last few slides relatively quickly, and then maybe take some of the discussion during our deliberation time. But there are a lot of lessons health systems can learn from other contexts. In terms of what we can see from our own states, what we can learn from other health systems like Vietnam, which have done fairly well, South Korea on its testing side, etc. But it basically all points towards the need for us to rebuild our health system to be more resilient and strong, because any strong health system will be able to better respond to any such future viral onslaught. And there are going to be more onslaughts. This is not going to be the last one in any way, right? So definitely more investment. Hopefully health will become a political issue. We have an outdated colonial law under which we are actually responding, the Epidemic Diseases Act of 1897. It needs to be updated. There is Disaster Management Act, which also is operational right now. But our primary act for public health is this act, which is really almost now 120, 130 years old and needs to be rapidly updated. We need to understand the implications of anything like this on our unique triple burden of care. So the infectious disease, non-infectious, things like mental health, road traffic accidents, etc. And then talk about how can we enable that in terms of partnerships with private sector, with civil society, with governance frameworks, which ensure that there is accountability. The other one area is, I think, our reliance on imports, especially in medical products. Anything from active pharmaceutical ingredients, we are very heavily reliant on China for that. Even in our response, we had a shortage of PPEs, personal protective equipment for our healthcare workers. COVID-19 test kits, a lot of that was imported also from countries like China. A lot of them had quality issues. Even medical equipment like ventilators and subparts of ventilators, etc. Again, a huge shortage because we are over-dependent on external imports for that, and that is certainly going to impact our health security. So there is a lot of work happening now on trying to figure out an Indian response for it. I am part of some of these efforts. There are other groups involved as well. And I think we need to see more of that, where we have domestic response, which focuses on strengthening our own internal systems of response. And certainly that means that we need to talk about Make in India for the health sector, but also leverage our IT strengths and our tech strengths in telemedicine, in using tech for training, in doing data collection. And there are some really good examples of this which can be used. We also need to focus on health security as being key to our national economic as well as social security. So it's not just about buying the tanks, but also ensuring that we have a strong health system. Centralized response, the advantages versus disadvantages. A lot of decision-making COVID-19 has been from Delhi and not enough from the state and district level, and that is also very worrisome. So what needs to be done to reform that is something I think we should all discuss, and maybe it can come up during our Q&A session, and how to bring nuance into that to ensure that we do this more at the district and state level. Again, data is key, but data is poor. If you don't have sound data, you cannot build a response to that, because policymakers like to see data to be able to respond, to be able to create evidence for a response. But we have divided data systems. You have an IDSP, the Integrated Disease Surveillance Program, which comes under one agency. There's a new special surveillance system which has been set up by ICMR. Sometimes seemingly they don't talk to each other. Data collation is an issue. Data quality is an issue. There is a lack of coherence on numbers. Sometimes, there is a claim made at the state level. There is a claim made at the central level. They don't seem to talk to each other sometimes, and that is causing some confusion as well. So it's, again, in other platforms, including in this article for the Hindu, we've talked about, a fragmented response is no good. We need to leverage what we have, including mechanisms like the National Crisis Management Committee, which can be set up at times of large natural calamities, and maybe this is a time to actually set that in action, and also have transparency in information and make data publicly available, so that anything that we see is based on sound data. And just as I was wrapping up my presentation preparation today, almost an hour ago, I saw that Sujata Rao has just published this article yesterday, I think, in The Wire, which again talks about the importance of many of the measures that I've hinted at. I'm sure these have also come up yesterday and will come up again today in the rest of the presentations. The need to simplify guidelines for how we respond, uniformity in definitions, decentralization to district level, expanding our testing and engaging civil society, which I presume also means the private sector with regulation in our response. And hopefully if we get all of that right, then we will have a much better response to COVID-19, which again, just to reiterate, is more of a test match, but also in ensuring that we build a health system for tomorrow, for the future, for the next century, and not something which is just short-term in nature. Again, there is a role we also need to think about for regional cooperation. Infections don't respect borders. We've seen that with polio. We've seen that with many other outbreaks of infectious diseases. It's important to talk to our neighbors. It's important to work with them to ensure that we are able to do south-to-south cooperation in research, in understanding clinical correlates, in understanding the spread of infection, and trying to reduce our dependence on multinationals like Gilead, which in this case has gone into licensing with multiple companies in both India, in countries like Pakistan, etc. But then, should we not have our own R&D powerhouses in our own industry, in our own academic centers, which are able to do these kinds of research studies and come up with the production of drugs and vaccines for our own needs as well? Should we be really relying on foreign sources, especially at times like this when scarcity of resources might be an issue? So I'll stop there. Thank you so much for listening in. Hopefully this will trigger some discussions, but I hope I also made some points which are useful for the larger picture in terms of our response. Thank you again.
Thank you so much, Dr. Bhan. It was not only a comprehensive wrap-up of the present COVID crisis, but also you touched upon various issues on which we really need to be attentive about, we need to improve about, and what we need to take care of in terms of both, जैसा प्रधानमंत्री कहते हैं, जान भी और जहान भी. So it was very enlightening, if I may say so. And naturally, as the little over 15 minutes time that is left is for Q&A, and those questions have also started coming in. And let me point out, in this speciality of this particular webinar, our guests are not just guests. They are experts in their own right, all right. And at the same time, a few of them have been participating throughout both the days, not just for their own slotted time. And if I may point out, Shri Vineet Chaudhary, who is going to be our next guest, was already there through the day yesterday. Dr. Muzaffar Ahmed was also there. And so was Professor Anita Carr. She was one of our guests yesterday. So she's also active now. And let me take up the first question from Professor Anita Carr to the present guest of ours, Dr. Bhan. She asks, and I quote her, Dr. Bhan, can you please comment on whether National Disaster Management Authority, NDMA, and the Epidemic Act overrides human rights law? Something to do with bioethics, your field, I guess, Dr. Bhan.
Yeah. Extremely important point and a good question also, I think, for our own deliberation. So, we've learned a lot from our responses to past infectious disease spread. And as I was hinting, a lot of that comes from diseases like HIV, where there was also stigma because of the initial sexual spread, etc. We have also international principles like the Syracuse principles, which focus on a public health response, which is grounded in human rights. And I think what we know as of today in terms of our response, including for areas like drug-resistant TB, is that human rights have to be at the heart of our public health response for multiple reasons. One is, if you don't have a rights-based response, then you also alienate communities very quickly. And when stigma is a factor, then that can also mean that communities are not willing to participate. As I said, the only measures that we know which work so far are public health measures which require public and community participation. But at times of pandemics, you will sometimes have sort of a quid pro quo which kicks in, which means to say that some individual liberties and community liberties might be sacrificed in the name of public health. That might include your privacy, that might include your individual liberty, and that is done in the interest of public health, but then it has to be balanced by a reciprocal requirement for the state to then provide for you. For example, if you're putting me into quarantine for say 2 weeks, then what is it that you as the state need to provide me for to ensure that I stay comfortable? It might be food, water, it's access to communication, knowing about my own health condition, Maybe has to be a financial angle to it, especially if I don't have access to regular earning, etc. And that is something which has also been done for other areas like drug-resistant TB. This is something which came up in XDR-TB, for example. Similarly, if you are going to sacrifice anyone's privacy and get their data and share it across the health system, then who should have access to it? How do you keep it confidential only to a certain number of people? So that, for example, what happened in COVID-19 was, there were lists of individuals who were found tested positive, which were circulating on WhatsApp groups. Anyone had access to that information. There were lists of homes which had been quarantined, and these were accessible to anyone. Is that a right-spaced response? Probably not. Of course, some people should have access to that information, but does everyone need to have access to that information? Could that lead to stigmatization of individuals or families? Absolutely. So, I mean, due care needs to be taken, because when people start seeing those kinds of things happening, then they are reluctant to participate. I would be reluctant to go get tested, because if I feel that might mean there could be potential stigmatization or harm to me or my family members, I would be protective towards them, and I wouldn't step forward and participate in a response. So again, it is also grounded in sound public health policy that to ensure public participation, you need to be respectful towards them. And hence, while there might be some sacrificing of rights, it should be done with due process, and there should be accountability to it.
Yeah. So this human right issue that you touched upon was one of the major issues that you pointed out was stigmatization. Other, I guess, Professor Carr would be having in mind would be the plight of migrants, Dr. Bhan. Because, I mean, fine, you lock down the whole country, but what about the millions and millions of people? At least yesterday I was counting, at least there would be 50 lakh to about 1 crore people who would be migrants on the roads. And there's a heart-rending news, latest news that I would like to share from UP. 23 migrants, even as we are having webinar now, 23 migrants die in a road accident in UP as their lorry is hit by a speeding truck on way to Jharkhand and Bihar. It is the latest news just a short while back. And the similar news of maybe a lesser numbers have been creeping in all the time. So, I mean, does this also involve human rights and how to address? Because already, even as I'm reading out the news, I can see that the condolences have been issued by the Prime Minister of India. But is that enough, Dr. Bhan?
Yeah, absolutely. It's a rights issue, it's an ethics issue, it's an equity issue. It's also a public health issue. So the large migrant population, as I was indicating, as they head back to their rural hinterland, will take back the infection with them. There is no way you're going to stop that. It's already happened. But that is partly because we never had measures to be able to prevent that. For a lot of time, we had just uncertainty for these individuals and families. They did not know when the economy would revive, when they might be able to get back to work. Their landlords were pressurizing them for rent. They didn't have access to food. The only food they could get access to was by standing in the sun for long periods of time. And even there was no certainty. So obviously people took the decision to go back, because at least, all of us want to be with our families at this point of time. And that applies to almost, I mean, everyone I think who's on this webinar probably is at home with their family members. And for many of these economic migrants, they also want to go back to their family members. And, why should you not expect them to, when all of us would want to be in the same situation? But the way they have had to go back, so if we have had flights to bring in people, we have a national mission to bring in flights and individuals who are stuck in other countries, but we don't have that kind of a mechanism for our own individuals who are economic migrants, then that is obviously not reflecting very well on our own response. So yes, for our migrants, we should have had better mechanisms. A lot of what has happened in terms of a response has actually been driven by civil society and by maybe in some ways by local self-governments, by local district level authorities, but not a coherent response from state level or central level. There is a lot of money, I think, which is now being collected and should be probably put to good use towards this. But we haven't seen that happen and roll out urgently enough. And I think that is also something which we need probably some urgency about. I think also, as I said, don't think of this as something which is a short-term phenomenon. This is going to have longer-term ramifications on these individuals, the families, as well as our economy. And hence, we need to then think about what we can do for that. But right now, what is urgent is ensuring people who are on our highways, who are on our train lines, walking back to their families 3,000 kilometers, 4,000 kilometers, young children who are out in this summer season, and obviously many deaths as well, as you were describing, for various reasons. It is very worrisome, and the least we should do is ensure that they have access to transport, etc., and they can go back to their families safely, and that we take care of them, and then talk about building and planning for a response which is more longer term. If we don't do that, then I think we have failed as a nation.
Yeah, we all agree with you, I'm sure. And the next question coming your way, Dr. Bhan, is from one of the PPF researchers, Ekoy Jam, and I quote, "Dear Sir, Anant Bhanji, what effective and possible steps can be suggested or taken up to reduce burden of household out-of-pocket healthcare expenditure by general public in relation to COVID-19?
Yeah, so a few things have been suggested. One, I think, is we have a national insurance system, as you know, Ayushman Bharat, but that doesn't cover everyone. It covers only families which are eligible for it, and the authorities have talked about covering COVID-19 related care under that package. So that is certainly helping. But the challenge again is that there is not enough coverage of the population. It's restricted to certain parts of the population, and it doesn't cover OPD care, right? It's outpatient care. It's only inpatient care as and when you get admitted, which is anyway in most cases free now if you go to a public facility. Once they get filled, then that obviously will be a problem. So I think the larger picture or the larger question we need to ask is, what kind of a health system do we want? Do we want an insurance-based health system, or do we want a tax-funded health system, which is based on the tenets of universal healthcare, which means that anyone, irrespective of whether you are eligible for a scheme or not, has access to quality healthcare, and ideally in the public sector, but if not, funded by the public sector. So even if I go to the private sector, then there is a way for me to get care, and if I can't pay for it, then at least the government has a mechanism to pay for it, and then quality is ensured. There is a governance mechanism so that there is no exploitation, etc. I'm sure many of you have seen those examples as well, where literally bills of lakhs being demanded and tests being overcharged, etc. One doesn't want to see that as well, especially at times like this. So I think we need to obviously at this time talk about how we ensure we have enhanced care for COVID-19, but also non-COVID-19 care. As I said, we don't want people to die of cancer. We don't want people to die because they couldn't get a dialysis, or women not to be able to deliver in hospitals because all hospitals have been closed down. There is no pregnancy care available. We don't want kids to miss out on their immunization doses unnecessarily. All of that needs to be ensured, and that I think is an important role for the government and the health services to play. This is not a matter of a few weeks. Now we're talking about literally about months and maybe years. So we need to talk about what we can do differently with and living with COVID-19 while ensuring that we get back to some semblance of normality in our response.
As I have been, thank you for throwing light on this particular question, Dr. Bhan. And as I have been reiterating that we are privileged to have such guests who are not just guests, but also active participants. Another example is the next question. It comes from one of our guests who would be the last, but not the least, Anjali Nair. And Anjali puts a question, and I quote Dr. Bhan: "Healthcare is an assurance in national health policy, but not a right." I repeat, healthcare is an assurance in national health policy, but not a right. What implications does that have on policy making and services? Asks Anjali Nair.
Yeah, so Anjali is a good question, and I think it's also rooted in what we can demand of our policymakers. For example, can I take someone to court or take the state to court for not providing quality services? And actually, there is one example which we can refer to, and that is the mental health sector. The only act we have so far where there is actually a legal requirement to offer services because it's enshrined as a right is mental health care. That's the Mental Health Care Act of India 2017. And if we can do that for mental health, and we managed to come out with an act which is fairly progressive, is grounded in rights, then why is it that we've not been able to do it for the rest of public health? And is there hence a role for one, activism, and two, pressure, as well as legal reform towards that? Some states have come out with progressive draft legislation, but they've not really been able to push it. So Rajasthan is an example, Gujarat is an example. Madhya Pradesh started on a public health act, a right to health legislation. But for various reasons, it seems to be the case that either it's not given enough priority, or sometimes there are lobbies which don't want it to happen. If there is anything we learn from COVID-19, as I was indicating, that health security is key to national security and our economic security, then it should mean that, one, we give health, we make health a political priority, including in our elections. We demand of our politicians that they focus on health, and that health is made into a right. And so, as Anjali is indicating, once we move from assurance to right, then probably we'll have even more rights to demand of our policymakers a more effective response than we've seen for COVID-19.
Great. And we can welcome Anjali visually also. We could see her. She was there on the screen. So what we can hope is, to begin with, when the Indian Constitution was implemented in early 1950s, right to work was also not among the fundamental rights. But recently, during last decade or so, right to work has also been incorporated. So let's hope, Dr. Bhan, that this right to health is also there in our one of the basic and fundamental rights, if not exactly the core of the fundamental rights as such. So that was a really very enlightening and very invigorating session. We had not just an explanation and overview and way forward, but also an interesting interactive session as well. So thank you very much, Dr. Bhan, for such that great session that we have had.